Well, my topic of today is, of course, about primary stability, implant loading, ISQ, and of course I would have also liked to discuss with you about microgeometry, but the time is running fast, and I will be very running fast also about this topic. Many of the, let's say, my topic was anticipated from Dr. Jan Gottlob, and I will also go fast in this initial part because I would like to discuss with you some more in details about our study, the results of our studies. Of course, this is a clinical case which is not so much challenging about immediate loading, immediate placement, and temporization, of course. The challenge here is about aesthetics, and I think all of you knows about that. But immediate loading is something which can be challenging in some specific area of the mouth and some specific clinical cases. So what I would like to discuss with you more in details today is about immediate loading. Because we know that delayed loading works well if we wait enough. Also in grafted sites, if we wait enough, the results are good, particularly today with the new implant concept about geometry and surfaces. We can increase dramatically the second stage success rate as well as the loading protocol and the loading success rate. The challenging for us today is about early or immediate loading because our patients are always asking us to shorten the healing time, to shorten the rehabilitation time. They want teeth as soon as possible. And if we can, we should be able to provide our patients the teeth as fast as possible. Of course, we know that immediate loading is not a problem. The problem seems to be micro-motion. And we, together with Professor Piattelli at the University of Chieti, around 20 years ago, we published some, at that time, talking about immediate loading was really against the odds. Nobody was talking about immediate loading at that time. It was something against the scientific world community because we, at that time, we only had the chance to wait. Submerged or unsubmerged healing, but waiting. So these papers where we published osseointegration on immediately loading implant under functional loading was something quite new. It was not new because we knew that implants from the past were immediately loaded, but the possibility to show osseointegration at histological level was something quite exciting because at that time immediate loading was connected to fibrous integration, not osseointegration. So showing osseointegration with immediate loading 20 years ago was something quite fascinating for us. That's why we published some case reports about that. And almost in the same period, few years later, 1995, the Salama brothers published a clinical paper showing the possibility to achieve osseointegration under immediate loading with the implants that were designed and sold and studied for delayed loading. And their vision, together with the old people from the old way, from the old implantology, their vision today is a light for us and for me particularly, because at that time they wrote this sentence, which is more than 15 years ago. The future may see routine immediate loading of certain implants placed under well-identified parameters and for selected application. Now we are 15 years after this paper. And which are the parameters? Bone quality, strong primary stability, surface, stabilization bicortically, rigid provisionalization restoration, cantilever, avoiding and axial loading. Now, 15 years later, what do we know about these parameters? Do we have any clearest idea about that? This is what I would like to discuss with you. And if we go through the literature, the old literature as well as the new literature, we can find the same parameters: mechanical stability, micro movement, splinting, implant geometry, surface, bone quality, again, surgical technique, bone density, and so on. But first of all, what is primary stability? What do you think primary stability is? What is your personal opinion about primary stability? It's something mechanical, of course, and it is nothing else that no micro movement at the interface between implant and the bone. You should be able to achieve something which does not move at the interface. So micro movement means we need a microscope. We need a magnification to see the micro movement. Otherwise, it is a macro. We can see by eyes, right? And this is a movie that I did on bone, soft, cancellous bone, placing an implant, applying a lateral load, and you can see some displacement. This is not a microscope. This is a standard video camera. But first of all, which is the biologic basis behind the concept of primary stability? Why we need primary stability? Is there any biology behind this concept? Yes, there is. The orthopedic people, they did a lot of studies about fracture healing and fracture stabilization, using plates, using screws, using any type of fixation to fix the fracture fragments. And what they found is something they call strain theory. They found that if you have a mobility of the fragments, when they are very tight, connected to each other after a fracture, if you have even a very small amount of micro movement, then osteoclasts enter into the gap and they start resorbing the bone. This is strange, right? Why? Why is that? The strain theory, which is supported from the data of the literature of the orthopedic people studies, they found that if the gap is narrow, is very thin, and you have a very thin layer of cells in this gap, and you have a small micro movement, microns, we are speaking about microns, then the movement can kill the cell because of the strain, compression or traction. If this gap is very small and you have a small micro movement, then the cell in the gap, they go towards death. And this death activates the resorption. And the resorption is nothing else than a system that the biology develops to increase the gap and allow the cell survive in this small space with the micromotion, because you have less strain for each single cell. So it's a biologic reaction to cell's death, to a threat of the cell survival. Now, this is the biology behind. But clinically, we are a clinician. We work in our clinical practice every day. So we need something that measures this topic, this parameter. Do we have any instruments that is able to measure clinically the stability? I mean, directly, I want to see if the implant is moving. Can I have any instruments which allows me to see if the implant is moving or not? No, there's nothing. There's nothing. We have something which can give us information about the primary stability, But these instruments are surrogate parameters. We have to keep in mind that we don't have a specific tool to measure in the mouth of the patient the micromobility. No way. Because if we try to apply a load and to measure everything is moving, the mouse is moving, so there is no way. The periotest, the RFA, the Osstell machine, or insertion torque, they can give you something which is related somehow to the stability. And this provides us information about primary stability, but it's not able to measure directly the primary stability, the micromotion. So are they reliable? This is our question. This is my question in my last year of research, trying to understand something more about this topic, because it's our clinical practice. We need an answer to these questions. So first of all, we did a study about insertion torque. We know insertion torque increased primary stability is logical. We know that. But how much micro movement we have if we increase the insertion torque? Is it related statistically? Is it possible to increase the stability by increasing the insertion torque? There is no study about that, because no one is able to measure the stability directly. So we developed the tools in vitro, something that Professor Gottlob showed you just before my lecture. And this tool is a very simple tool. We have a bone holder. We keep the bone into a holder which is very tight, no movement. Then we put an implant into the bone with a long abutment, more than 10 millimeters. Then we applied a lateral load on the abutment 10 millimeters above the crest, and we measure the displacement of the abutment. If you keep in mind that the rotation point is at the crest for each implant, you can imagine that the movement you have in the abutment is exactly the same movement you have 10 millimeters below the crest. So this is what we have done. The first study we published was comparing the insertion torque to the stability. And also, we tested different bone qualities. And we selected different bone qualities from butchery bones, which quite well reflected the density of the jaw. Very dense, compact bone, the first one we called dense bone, and then intermediate or medium bone, or we call normal bone, which has 2 to 3 millimeter cortical layer and then cancellous structure below. And then the last one is the soft bone, which is our challenge. So 3 types of bone, different insertion torque. We place the implant with different surgical technique in order to achieve different insertion torque after seating the implants. And then we measure the stability or the mobility of each single implant in different situations. So here you can see, this is the insertion torque, 20, 35, 45 Newton centimeter, 70, and 100. And this is dense bone, normal bone, and soft bone. As you can see here, if we increase the insertion torque from 20 to 100, we have a reduction of the micro movement. Of course, it's normal, it's logical, but here we were able to measure it, and this is the first time. Second one, normal bone, the same amount of insertion torque, 20, 35, 70, 100, a little bit higher level of micro movement from 25 to 30 and 40. And if we go in soft bone, which is cancellous bone, type 4 bone, then we only were able to put the implant with 20 and 35. We were not able to place the implant more than 45. Why is this? What do you think about that? Because you crack the bone. If you try to increase the insertion torque, then the implant becomes spinner. You lose the stability. So with this specific type of implants, we were only able to go up to 35, not more. Then we lose the stability, and the implant became spinners. But look at the micromobility. With 20 newtons, the mobility was 90 microns, and with 35 newtons was 70 microns. Now, I would like you to reflect on this number, just a short, let's say, look at this difference. 20 Newton in dense bone, in normal bone, and in soft bone is the same insertion torque, the same implants, but very different micromovement. So insertion torque is a good indicator of the stability, but you have to keep in mind that bone density is much more important according to the stability. You can have the same insertion torque, 20 or 35, but the micromotion can be dramatically different from 30 microns to 100 microns. And as we have seen before, 100 microns or even 50 microns can be the limits of micromotion that produce bone resorption. So be careful not to rely only on insertion torque. You also have to measure the bone density. And we have seen before in the lecture before that you can do it under the CT scan using the Hounsfield value. And it is very important to do it before going to the surgery. You have to treatment plan the case, not only with the height and the width of the bone, but also with the density of the bone. It is very important. So insertion torque is related to primary stability. Definitely. We know that, now we have measured it. But also extensively is related to bone density. The same value of insertion torque may correspond to very different micromotion. And in soft bone it's difficult to achieve very good primary stability. What about the ISQ? Is it related to the micromovement? We did the same study, and you have seen the study of Dr. Gottlow, Professor Sennerby, presented right now. We did the same study. We published it last year in the Journal of Osteology and Biomaterials, which you can find free open access on the internet at the website www.osteobiome.com. You can just register and you can have access to the paper. And these are the results, which are quite similar to the results of, presented previously. Means that we are saying the truth because they were independent studies. And you can see here different density, soft bone, medium bone, hard bone. You can see the spreading of the values comparing micromotion to ISQ. So are they related? We did a statistical significant test, and they are definitely statistically related. If you compare dense bone, medium bone, and soft bone, you can see that dense bone is very high, 74, medium bone is 73, soft bone is 72.5. So the spreading of the values are not very high. In our cases, we try to achieve good primary stability always by increasing insertion torque. So all the implants were almost stable. But the difference in the value of the ISQ is not so spread. We never had an implant which was below 60 or 65. All our cases were quite high. And here you can see the differences in dense, medium, and soft bone. And in dense and medium bone, the statistical relationship was very good, highly significant. Soft bone, a little bit less, but still very significant. So conclusion is that ISQ is related to the primary stability, and is a good way to measure the primary stability. It's not enough insertion torque, as we have seen in the clinical stuff in the previous lecture. Insertion torque is good, is not enough. You need also bone density, and ISQ provide a good indication of the micromobility. This is not only our stuff, there are a lot of papers, and in this meta-analysis that was published in 2009, there were 47 studies compared statistically, and they found a strict relationship between insertion torque and RFA. So it's related both clinically and in vitro study. Now let's focus just shortly on the implant geometry, which is another topic related to the primary stability. How do you select your implants? This is my question for you. Apart from the cost or the name, in the same book where the company today provide you with so many different implants, everybody sell anything now. We don't have the implant from Nobel, the implant from Straumann, the implant from Astra. Almost any company give you any type of implants. So how can you select the geometry, the shape? How do you choose? Which one do you choose and how do you select it? There's no science behind. There's nothing behind. We don't have information about that. We don't know the difference. For example, in the stability after placement, they just give us, anecdotal information. They tell us this is better, this is lower. No data between this. How is it possible? It's now 15 years of osseointegration. So we set up again another study, the same model, using the same in vitro model, stability measurements, different bone density, 3 different bone density, always the same. We try to be very strict with the research model because we want to have comparable data. As you could see from the study of Gottlob, we were almost comparable between each other. This is science. So different in vitro density, different insertion torque again, and we selected 3 implant geometry. Standard Brannemann screw, we used 3i implants, a Zimmer screw vent, taper screw vent, and the new shape from the Nobel Active, which is said to be very high stability, the most stable implant on the market. So we compared the 3 brands, the 3 geometry, pardon me, and different insertion torque and soft bone. Now, we don't have time to go through all the data, but you can see that we are missing some bars here. Particularly, we lost the 3i implants at 45, 70 newtons. We were not in soft bone. We were not able to place the implant, the standard Brannemann screw, above 30 newtons. Because again, if we try to screw it in, the implant becomes spinners because the plate of the implant stick on the cortical level and the trabeculi below the cortical level gets broken and the implant becomes spinner. But with different implant geometries, like Nobel and Zimmer, we were able to go up to 70 newtons in soft bone. In soft bone. We are speaking about soft bone. So if we select a different implant shape, we could achieve higher insertion torque. Also in soft bone, of course, we use an under-prepared site, 2 millimeters just. We only use 2 millimeters drill. And we were able to reduce the insertion torque as well as the micro movement. And if you compare the different design, you can see that the Nobel Active, the same level of insertion torque, 45, was very much more mobile than the standard taper screw-vent implant, also at 70 Newton. So geometry can make a difference in the stability. And this is in medium bone data, and you can see almost the same level. It seems that, again, Zimmer is, screw-vent is being a little bit better, is winning. And in dense bone, we were not able to go to place implant with 20 newtons, which is very low. Now, the conclusion is that the specific implant design may affect the primary stability differently, but we must test it. We cannot just have an idea. We need tests. We need tests that provide us the level of micromovement, the level of insertion torque. And nowadays, we don't have this test yet. We need to develop this data. But if we go so high with the insertion torque, what does it happen? Why we were placing implants at 35 Newton until nowadays? Why? Do you know why? Most of the paper in the literature, almost all the paper in the literature were addressing this issue, saying that if you increase the insertion torque too much, above a certain level, which is 45 Newton centimeter, you can create disturbance in the local microcirculation. You know what does it mean? You close the canal of the vessels in dense bone that brings blood to osteocytes, and the osteocytes die. And the death of the osteocyte is supposed to lead necrosis and bone resorption. And of course, implant failure, right? Well, if you go through the literature, there is no paper who ever showed something like that. No one was ever able to show that if you increase the pressure into the bone, you have bone resorption. There is no proof about that. And it took me 1 year to go through all the literature, orthopedic literature, dental literature, implant literature, to find finally that no one ever showed this. This is only a personal opinion of the authors who wrote those papers, nothing else. So we set up a study, and it took me a long way to publish it, because this was completely against the way of thinking, the knowledge we had. It takes me years to get this paper published. It's more than 5 years I did this study, and it was published right now. But finally, we were able to produce this data. And we placed the implant in the jaw of the sheep, in the lower mandible, because we have a consistent amount of dense, compact, mature bone, 3 to 4 millimeters thick. If I make an extraction in dogs, for example, which is the normal way of doing implant studies, experimental in animal, make extraction, wait 3 months, place the implant. You never get dense bone. After 3 months, have you ever placed an implant in your patients after 3 months from an extraction? How many of you have done this? I think most of you, right? Which kind of bone do you find there? Type 3? Type 2, if you are very lucky. Never dense bone. That's why we went in the lower side of the mandible. We drill holes in dense, mature, compact lamellar bone, and we did it with split mouth design. On one side, very high torque. The mean insertion torque was 110 Newton centimeter, 110. The peak was up to 170, almost 200 Newtons. And remember that the mean level is 35 Newton centimeter, insertion torque, the average we can achieve normally. On the other side, we went very low insertion torque, 10 newtons. Why? We were interested in looking at the differences. So we did our best to see the differences. Very low, very high. And we did a setup for healing 1, 2 weeks, 3 weeks, 4 weeks, 6 weeks for implant on each side, reverse torque test, histology, and so on. And just a few slides, if you allow me to complete my lecture, I will be very fast. Thank you. This is a comparison between 1 week low torque and high torque. As you can see here, you have a gap. 10 newtons means you put your implants and just leave it. Don't screw so much. The implant is almost unstable. You can do with your finger very easily. On the other side, where we had 110 newtons, it was very high, you have a perfect fitting between the implant and the bone. As you can see, here no gap, some gaps here. Now, you can see the graph of the development of the osseointegration. From the initial healing 1 week up to 6 weeks, you can see an increase in the bone-to-implant contact between the 3rd and the 4th week in the low insertion torque group. In the high insertion torque, we had immediately primary bone-to-implant contact, and it just grows. Now, if you compare 1 week, 3 weeks in low torque and high torque, you can see the gap healing here. This gap was filled with new bone. And you can see this bone. Which kind of bone is it? Woven bone, immature bone. This is a callus, primary bone callus, very low quality. On the other side, do you have any gap here? No gap. Which kind of healing? Just remodeling. And this is just biology. We know that. Going into the orthopedic literature. This is called gap healing. This is called primary bone healing. The same you can find in the fracture healing. Exactly the same. Nothing new under the sun. Now, what's the difference at 6 weeks? Low torque, you have remodeling of the woven bone callus, and you have some mature bone primary osteons in the gap. In the high torque group, you have just remodeling, nothing else. But to me, the most striking information is this one, the mechanical data. If you see the reverse torque after 1 week, and you see the insertion torque, in 1 week, we lost 50% of the stability. We placed the implant with 110 newtons, and after 1 week, we were able to unscrew with 60. So we lost 50% of the stability in just 1 week. And then it stays the same until the 4th week again. And then a little bit drop again at 6 weeks. This is remodeling. What about the low insertion torque? We placed the implant with 10 newtons. After 1 week, again 10 newtons. 2 weeks, again 10 newtons. 3 weeks, 10 newtons. 4 weeks, 40 newtons. 3 times increase in the strength, 3 times. So this gives us some kind of answer to the famous graph of Dr. Salamas, the hypothesis of primary stability lost and secondary stability gain. And what's the time frame? In just 1 week, we lose the stability. And 4 weeks to increase the secondary stability. So we have a week period. And this week period is between the 1st weeks to the 4th week. In this period, we must be very careful not to disturb the healing, not to go to our implants and try to screw and unscrew the abutments to make our test of the framework and so on, because we are at risk to move the implants in a weak period when bone is forming and secondary stability is developing. Of course, this is an animal study. We cannot just transfer the results from animals to humans, definitely. But we have clinical studies supporting this data. There are more and more studies going out in the literature showing this data also can be applied to humans. This is the very first one, 2005, Dr. Ottoni showed that if you increase the insertion torque, you reduce the risk of failures in immediate loading. And also a study that was recently published by Dr. Senerbi and Dr. Kayat in 2011, where they almost did the same study we did in animals. They did it in humans, using almost the same level. We were not doing the same study. We were separate, independent, but we did the same. And the results are again the same. 176 was the maximum peak insertion torque. No implant lost, no marginal bone loss, nothing. And these are just few clinical cases Dr. Kayak gave to me to support my study. So where are we now after 15 years? Can we give answers to this question, old question now? Some answer. We have some answer. We can measure primary stability, and this is very important. We can measure bone quality. Again, this is a very important stuff. We have instruments to provide us all these informations. We know we have thresholds of stability. If we are able to increase the stability, we could increase the success rate. No risk to increase the insertion torque so much high. The only problem is with implants. Implants can break if you increase the torque too much. You can break the hexagon, you can break the internal X, you can break the mount, so be careful when you use your implant. Test it before going to the mouth of the patient, because if you go so much high with the insertion torque, you can be in trouble in your chair. So test it in vitro before going to the patient to see how much force can your implant system withstand. But still we have some open questions. Which are the thresholds of implant failure under immediate loading? And thanks, Professor Jan Gottlow showed us some limits about that. We still need some information about early loading and also some protocols from other clinical cases, which is not full arch or anterior single tooth. Thank you so much for your attention.